Regeneron COVID-19 trial that we're going to start at Good Sam next week. Dr. Syed is the principal investigator. Do you know Dr. Syed?
Yes.
Okay.
Yeah.
So here's our topics of discussion this evening, and I'll be giving you a brief study overview. I'll talk about the study collaboration between St. Francis and Good Sam, patient eligibility, informed consent process, how to infuse the study drug, maintaining the blind, the test during study participation, test after the patient is discharged, and the research study team contact information. And then we have tools for the staff, the clinical nursing staff. You probably don't know, but you will know now that Good Samaritan has an oncology research program. It's brand new. A nurse from St. Francis will be involved with it as well as a coordinator named Samantha Frontario. I'm the administrative director of research at St. Francis. This study went through a central IRB and was approved by the central IRB. Good Samaritan IRB authorized using the central IRB. Just so you know that we went through all the processes for this trial. The sponsor is Regeneron, and the sponsor is about monoclonal antibodies. These antibodies are labeled 10933 and 10987, and the study is known as 2066, and they actually do call it the SPIKE trial because of the spike on the COVID virus that looks like a crown where it got its name, Corona. Oh, and now we have some joiners. We have Jerry and Andy Conrad. So I'll wait for them. Andy Conrad at Alansad.
Hello.
Hello. First time I've seen a family photo. You have a cute baby.
Yeah.
And Jerry, are you on? Well, it looks like Jerry's trying to get on. But welcome. This is the Regeneron trial for COVID-19 review. And it's the study of monoclonal antibodies, and the treatment is anticipated to neutralize the coronavirus with a reduced likelihood of the virus escaping because of the genetic mutations from the antibodies. It's supposed to reduce the SARS viral shedding and the disease progression. It's a randomized, double-blinded, placebo-controlled protocol, and the two monoclonal antibodies are given in combination therapy along with a placebo. It's designed for patients that are hospitalized with COVID-19. These are the antibodies that President Trump received. He was not part of a trial. He did get emergency use authorized. Regeneron is coming out with frequent press releases about their monoclonal antibodies. They just shared this last week that the same monoclonal antibodies used in the inpatient trial were used for outpatients, and they had very positive responses for patients that were enrolled in the trial. So they are seeking an emergency use authorization with the FDA. We'll see how that goes. And this is a press release that we got October 30th, that there were originally 4 cohorts in this trial: patients on low-flow oxygen, patients not requiring oxygen, patients on high-flow and mechanical ventilation. And the cohort 2 and 3 are on hold because the Data Monitoring Committee wants to review the data on those 2 patient groups. So right now, we're only going to be enrolling cohort 1 and 1A. And it's strongly popular cohorts. They're getting a lot of enrollment. They're not closing enrollment, but they just sent out a notice today that enrollment is moving along very well. Before we can enroll a patient in a clinical trial, we have to make sure they meet the inclusion-exclusion criteria, and the research team does that. We will get notice from Dr. Syed that there's a potential patient, and we will go through the inclusion-exclusion list. We'll make sure that they provide the research-informed consent, that all of these are answered yes, that they are 18 years or older, that they have a positive SARS antigen or molecular diagnostic test less than 72 hours prior to randomization. They can have a test from another site as long as it meets this time window. And my example is if the patient went to CityMD, had a positive test, and then came to Good Samaritan because of symptoms. The symptom onset is less than or equal to 10 days before randomization. They can be hospitalized for less than or equal to 72 hours, and they have to be in one of these cohorts, not requiring supplemental oxygen, or their O2 sat is greater than 93% on low-flow O2 via nasal cannula, simple face mask, or other similar device. All of the exclusion criteria have to be answered no, and this, again, is part of the research team's roles and responsibilities. We'll take care of this, just so you know that we are diligently reviewing the patient's history. They have to have a survival rate greater than 48 hours. They cannot receive ECMO, no new onset seizure or stroke during hospitalization. They cannot have been initiated on renal replacement therapy because of COVID. No vasopressors because of circulatory shock. Cannot have received CPI or IVG in the past 5 months or a plan to administer such. Participation in a clinical research trial, including any double-blind study, is permitted if it's beyond the 30 days and more than 5 half-lives prior to the screening visit. The use of remdesivir, hydroxychloroquine, or other treatments, not convalescent plasma or IVIG, in the context of a local standard of care or an open-label study or compassionate use protocol is permitted. Oops, sorry about that. I have a mouse, I just touch it and it moves forward. If the patient has any physical exams or findings, history, or illness that may confound the study results or put an additional risk to the subject, they will not be enrolled. If they have an allergy or hypersensitivity to components of the study drug, they will not be enrolled. Any pregnant or breastfeeding or woman of childbearing potential who's not using a highly reliable pregnancy avoidance method such as abstinence will not be enrolled. The research staff, we will coordinate the activities related to the informed consent with Dr. Syed, with the nursing staff, and the patient and their family. Originally, we had a call today. Jennifer Brown was on the call, and we are looking into the possibility that patients will come into the ER and then go to a unit before they're moved up to the MICU. When we initially designed this plan, we thought it would also include the other 2 cohorts that would include intubated patients, but it's changed a bit. So we will may have the informed consent obtained outside of MICU, but they will still be cohorted in MICU and have all the administration of the study drug there. There's a whole list of things we have to do on day 1, and I'll show you that in a second. But the big thing, takeaway, is that patients must have a research-informed consent prior to any study-related activities, which even include a lab draw just specifically for the study, any nasal pharyngeal swab, or the study drug infusion. And we can all remind each other, do you have the consent? Where is the consent? The consent will be placed in the shadow chart when it's signed, and will also be uploaded into Epic. Patients must have consent translated into their native language, and I'm working with the Western IRB to get that. And if the patient cannot sign a consent, a LAR will need to provide the research-informed consent. And I'll show you all of these documents in the tools section. Patients may receive the standard of care treatments. That includes antiviral therapies and immune-based therapies such as tocilizumab, sarilumab, steroids, or others. So now I'm going to show you the schedule of events that are going to occur during this trial. This is our tracking tool we'll use in research. You will not have to have this or know this, but know that we are tracking the patient. It tells you here the multidisciplinary team and the tasks that have to be done in order of events. So while we're screening, we have to confirm the patient is eligible, obtain the informed consent, and make sure there's a positive COVID test. Then Dr. Saya can order the local labs that will be resulted at Good Samaritan Hospital, and they are the usual labs: CBC, CMP, CRP, ferritin, LDH, D-dimer, PT-INR, and APTT. Once those are drawn, we will check to make sure they are resulted. We want to make sure that there's no difference from baseline. I'm just going to write myself in. I just have to write a note about the local labs. And my question, I'll follow up with everyone on Monday. We will then have a research nasal swab that we will want to be obtained by the nurse in MICU. And that comes in a kit that we will have. We will fill out the paperwork, the labels, we'll give it to you, and we'll make sure it gets down to the lab. It will be sent off-site. It's not going to be processed in the lab as it usually is. And the results will be evident for everybody in the unit or the hospital. It's only part of research. The next thing is that we will ask you to take vital signs before the dose, as you normally would. And then we have a central lab for blood draws, which include tubes that will be sent off-site to a research lab as part of the study, and we will not get any values associated. Patient will be randomized, and there are 3 arms. I'll show you those in a second. Pharmacy will be notified of what the randomization code, and they'll prepare the study drug. They will then bring the study drug up to the unit. They'll have a responsibility for the study drug accountability, and then the drug will be infused. It's a 1-hour, one-time infusion. It will be infused in the MICU. We require vital signs post and then a central lab for blood draw. Same situation as before, so before and after. And then we do our research duties here. Every other day, the patient will get a nasal swab that will be sent off-site up until day 15. They may go home before day 15, and that's really important that you notify us the day of discharge, 24 hours, so that we can order lab work, local labs, another nasal swab, and blood draws for those central labs. These are all of the things we do during the patient's hospitalization in terms of collecting data. One of the important things we'll do on the day of the infusion is we will call a home health agency so they know that the patient is going to be discharged and will be followed by this home health agency to have all the testing done at home. So the patient doesn't have to stay in the hospital for 29 days, but we will be following them for 29 days and then a post-discharge period as well. Okay. So here's our randomization slide. The research team will obtain the randomization code. Pharmacy will deliver to MICU. It's very important that we maintain the blind. It's a 1-to-1 randomization to the following: the monoclonal antibodies at 2.4 grams, IV single dose, or 8 grams, or a placebo. So this will all be blinded. Don't ask anyone what the patient is receiving. It's really, really important that we maintain the blind. And why do I say don't ask? Because sometimes that becomes a reflex. If you see someone from the pharmacy, it will be an Epic as study drug. What is the mechanism of action? These are fully human antibodies that bind the receptors domain of the SARS-CoV-2 protein and block the interaction with the ACE inhibitors and prevents the viral load from progressing. And it's anticipated that this will neutralize the SARS-CoV virus with a reduced likelihood of viral escape due to genetic mutations. The study drug is a single one-day infusion via an 18 or 20 gauge peripheral or central line. It's to be infused with a 0.2 micron inline filter, infused over 1 hour, plus or minus 15 minutes. When the infusion is almost empty, you hang up a 50 ml bag of 0.9 normal saline and infuse at the same study drug at same rate so that we can be assured that the full dose was infused. Then we monitor for emergent reactions, adverse events. The infusion should be interrupted if any of the following occur: sustained or severe cough, rigors, chills, rash, pruritus, hives, welt wheals, diaphoresis, hypotension, dyspnea, vomiting, and flushing. The reaction should be treated, and the infusion may be restarted at 50% of the original rate. We must notify Dr. Syed of any suspected adverse drug reaction. We don't make the decision to restart, she does.
Sorry, I just had a question about that. Some of those are overlapping with symptoms of COVID.
Right.
So we should still stop the thing if they're, I mean, if they have a recurring cough, you know, should we be documenting that prior to starting infusion or something?
Yes. And because it's only an hour infusion, I think, you know, we'll see what kind of reaction the patient is having. And Dr. Syed's going to be nearby. We're only going to do this Monday through Friday when people are available and around. So I don't imagine it's going to be hard to find her and say, listen, the patient had a cough before, but it's the same cough. That to me would continue with the infusion. But if you're saying, I noticed the patient's coughing a lot more and we're 10 minutes into the study drug, do you want us to continue? And she may say, treat the cough or lower the study drug or terminate it. It's really her call. So that's a really good question. Nobody's asked that, so thank you.
All right, thank you.
The infusion should be terminated and not restarted if any of the following adverse events: anaphylaxis, laryngopharyngeal edema, severe bronchospasm, chest pain, seizure, or severe hypotension. Again, we would notify Dr. Syed right away. I would stop it and call her immediately and say, patient's having one of these symptoms. Study drug is stopped, please advise. And she would have to say terminate. But here, with these types of symptomatic events, I would say we call her. I would still stop it, but call her. And then she can say restart it, or maybe treat the symptoms and then restart it at 50% of the original rate. And we have a meeting with her on Monday, and I'm going to go over that. This is a list of all the activities that the patient will undergo while in the NICU and what the nurse will do. We just wanted to condense that long list so that this was handy for you to understand what we are expecting or what we need help with, really. Is a lot of nasal swabs every other day, and that's to see what effect the antibodies have on the virus if the patient is still testing positive. And then the lab drugs are day 7 and day 15, day 20, day 29. It's very important to make sure you contact the research department within 24 hours of knowing of the patient's discharge, because we'll have to do those tests, and we'll also have to order kits for them to go home with, and we will either hand deliver them to the patient or FedEx them. I'm leaning towards FedEx because the patient doesn't need to carry all that home. Any labs, we're going to coordinate with the lab at 3038. The central labs, including the nasal swabs, will be handed by research and then delivered down to the lab. We'll just take care of that and the paperwork. The hospitalization, nasal swabs every other day. Again, we'll have the paperwork filled out, make sure everything's labeled, and discharge, you must give us 24-hour notice. These are slides that just repeat what I have just said. But we'll coordinate with you and the RN staff and the PI for the nasal swabs, the local labs, the central labs, and that you will contact the research team before the patient is discharged. We have a contact sheet we'll make readily available. Now we're moving into the tools section. This is just a repeat. This is our contact information, and we'll have a sheet with all the contact info readily available. We're waiting for zone phones. We'll have those on Monday. This is a tool that will be given to all the nurses for every patient, and it's really just a summary of everything I said already. This is a document that you can put at the patient's bedside, outside the window, wherever in your unit, so you all know that this is a research patient. The informed consent process, the unsigned informed consent needs to be handed to the patient by a healthcare worker who's entering the room. We will have a three-way phone call with the patient and a impartial witness. You may not be that impartial witness, or you may not be taking care of the patient, and you will be listening to the call while we explain everything about the trial. The patient will have a phone and can take a picture of the page that they sign. And then we use this to document this process. It's for our records. We will handle the process if we need to involve an LAR, but we will reach out to the nurse taking care of the patient and say, is this a good day for you, for the patient? What is the patient like right now? Are they sleeping? Are they awake? Are they someone that we want to approach for the study? When do you think might be a good time for us to handle this? So we'll rely on the nurse to give us that feedback. We will contact whoever is the LAR. We'll look in Epic. Evidently, it's readily available, but we may ask you as well. And we'll handle calling them and getting them the information they need to make a decision whether or not this is the right thing for the patient. This is a slide of what the informed consent looks like. And it shows that it's IRB approved. And we are very cognizant of the date, the version, and the number of pages. And it contains all the elements that the FDA requires for an informed consent. And the patient is given it and is asked to read it. And that's, reading it is one thing, but the real process is the discussion that will be had after the patient is handed this consent. And this is the page 16 that the patient will be asked to sign. Write the name, signature, and the date. We will take care of getting the legally authorized rep to sign here if that's needed. We and Dr. Syed are delegated to sign the consent along with Dr. Syed, so one of us will sign or Dr. Syed. And the witness would be, if you are asked to be an impartial witness, when you sign this, you're attesting that you witnessed the entire consent discussion. That can be over the phone, and that the above-named participant received a verbal and written description of the study, and the individual had sufficient time to consider this information, had an opportunity to ask questions, and agreed to participate in the study. Your name, signature, and date. And then I realize we have a blank page here. That's a mistake, but we're just going to leave it for now because every page is noted. With research, you just can't get rid of that final page. You know, every page number matters. That concludes this session. I really want to thank you for your collaboration and time throughout the study. Anytime you have questions, please reach out to Dr. Syed or anybody in the research team. You can email us. We'll give you all our contact or call us anytime, even if you're involved with the patient. if you said, hey, day 3, I noticed the patient has a rash, put it in Epic, write and document. We will be looking through Epic several times a day, and we'll be documenting all the events that occur while the patient is hospitalized. So we'll be familiar with the patient. We were a big part of the Remdesivir program at Good Sam. The research nurses at St. Francis monitored, consented, enrolled, and followed those patients throughout their entire hospitalization. There were 21 patients. We worked closely with Heidi and Dr. Syed, so we're familiar with your team, and we think we'll have a great team here with this and hope it's a good study for the patients. So anybody have any questions?
No, thank you.
I'm good,
All right.
thank you.
All right, make sure you fill out whatever you need so you can document your attendance with Karen.
Yes, I wrote down the names. I was
Oh,
sorry, I was a
Karen's
little
here.
late. Yeah, I was late getting to because my computer died and I had to go to the phone. So, but yes,
right.
I do have your names. I will be sending out evaluations to those people who have completed all the components. Please fill those out, get them back to me. And if you have any questions at all, you can text me, shoot me an email, talk to me, and I will vet it through the appropriate members of the team if I don't have the answer.
Thank you, Karen.
You're welcome. Thank you guys all for joining us tonight. Really appreciate it.
Yes.
I know time is precious, so thank you.
I tried to make it as informative and be efficient.
Yes, thank you so much, Liz.
Okay.
And I will see you at 6.
All right, I'm here.
Okay. All right. Thank you.
Thank
Bye-bye.
you. Thank
Okay.
you.
Bye now.
Bye.